Thank you for joining. We are very fortunate today to have Dr. Tomek Piorkowski to give us a presentation today, which is going to be about alternatives to blood products for a Jehovah's Witness medical patient. Dr. Tomek is a hematopathologist working at Pathcare Laboratories. He qualified as a laboratory hematologist in 2023 and briefly worked at the South African National Blood Service before moving over to Pathcare. Prior to specializing, he worked as a general practitioner in various private healthcare roles and lectured part-time at the University of Pretoria. He's got a few special interests that include consultative hematology, laboratory quality improvement, morphology, and the business side of healthcare. Thank you so much for giving us this presentation. Over to you.
Thank you for the kind introduction. So the origin of this presentation is I have had many clinicians complaining that they need a practical guide to managing a patient who's refusing blood products, in particular the Jehovah's Witness. So I thought I would meet the demand and come up with a presentation. Just to note that I'm not a clinician, so this is more of an academic exercise for me. I just went to see what does the literature say. And the fact is that there's very little literature, and people tend to run away from this topic. So I've tried to sort of find what is the most useful information that is available in the literature. I'm not going to talk about how to manage underlying medical conditions such as iron deficiency or megaloblastic anemia, etc. I'm also not going to talk about the surgical side of things. I'm sticking purely to sort of the medical sort of scenario where you want to give the patient blood, but either the patient's a Jehovah's Witness or has some other reason for refusing a blood product, and you need to come up with an alternative. So I'm hoping this is going to be fairly practical. So there are three products we're going to discuss, packed red cells, plasma, and platelets. So we're going to start with the packed red cells. And the most sort of useful approach, first of all, let's discuss anemia as a risk factor. So this is from one of my references where they looked at mortality rates from two studies and the association between mortality and HB. You'll see that above an HB of 7, there's very little mortality, and that's in keeping with modern transfusion medicine guidelines that you should only transfuse the non-bleeding patient once the HB drops below 7, because there's not much benefit above HB of between 7 to 8. As you go below 7, your mortality increases and increases in proportion to the anemia, with HB of less than 2 being a very high risk factor for mortality in the patients assessed by these researchers. And taking the two studies together, the statistics show that if for every 1 gram per deciliter decrease in HB below 8 grams per deciliter, the odds of death increase by 2.5-fold. So anemia is a risk factor for mortality and morbidity, and that is why it has to be managed. Now, in the patient that's refusing a blood product, that can be challenging, but this very nice protocol published by the University of Michigan has a sort of very nice detailed approach in how they manage patients that are refusing blood products. And so I just want to go through this overview, and then we'll zoom into more specific aspects. But as I mentioned, international consensus for transfusion is you should only transfuse a patient once the HB is less than 7 grams per deciliter if the patient is not bleeding. And once the HB is less than 7 and the patient is refusing blood products, at the University of Michigan, they have an anemia protocol for patients that are declining red cells, which includes erythropoietin or erythropoietic stimulating agent. They give 40,000 units daily until the HB goes up. and then go to weekly dosing to maintain HB. They also give iron intravenously along with that, and we'll go into the rationale for that, as well as some vitamin support. So all patients will get this. Then what they will do is they'll see, okay, while we're doing this, is the patient critical? Is the patient very unstable at the moment? And they have hemoglobin oxygen carriers available at their center. So we'll briefly discuss hemoglobin oxygen carriers on a later slide. But essentially, if the anemia is very critical and they want to give the patient some bridging therapy, they will give hemoglobin-based oxygen carrier called Hemopure. If the patient is not critical, they'll consider giving a hemoglobin-based oxygen carrier if the HP is less than 5. But if the patient is reasonably stable, HP is more than 5, they will just wait for this anemia protocol to kick in. Along the way, they're going to monitor the HB, and because methemoglobinemia is a complication of Hemopure, they will monitor methemoglobin, but they limit their blood draws and they try to monitor the patient using only daily blood gases, so limiting the blood draw to 0.3 mils to 1 mil per day. They control any bleeding and optimize the calcium to prevent coagulopathy. Reduce oxygen consumption by controlling anything that might increase the metabolic rate. Give supplemental oxygen to maintain a slightly higher saturation of 95% and avoid intravenous fluids and hemodilution, and potentially give diuretics to cause hemoconcentration. So that's in a nutshell, but I want to just deep dive more into certain aspects of that protocol. So the rationale of the erythropoietin stimulating agents is that they induce proliferation of erythroid cells and differentiation of erythroid cells in the bone marrow, basically promoting red cell production. They also prevent apoptosis in the bone marrow, which also helps to increase the availability of red cells. They also induce hypoxia-inducible factor, which also has an anti-apoptotic action, and potentially they affect renal tubular function, leading to a decrease in plasma volume, which can cause some hemoconcentration. And high pharmacological doses of erythropoietin can overcome the erythropoietin resistance due to hepcidin, which is seen in anemia of inflammation and chronic disease. So especially your elderly patients with many comorbidities with anemia, even if they have anemia of chronic disease contributing to the anemia, the high erythropoietin doses can overcome that inhibition of red cell production. So what kind of response could you expect to giving high doses of erythropoietin? You expect a reticulocytosis usually by day 3, and by day 7, you're given the equivalent of 1 blood unit through high-dose erythropoietin therapy. So not quite as quick as giving a unit of blood, but after 7 days of treatment, it's the equivalent of having given a unit. That said, you will not get your maximum response if you don't give iron. These patients will typically develop a relative iron deficiency, even if their iron stores are adequate at commencement of treatment. They need iron supplementation. The optimal dose of erythropoietin for this protocol is not so scientifically established. So at the University of Michigan, they choose that dose of 40,000 units daily. I will briefly present another protocol which has a different dosage, and carry on until you reach your transfusion threshold. Erythropoietin does have an increased risk of thromboembolism, so that needs to be monitored. And I quoted the authors directly in terms of the iron therapy, and that the combination of daily erythropoietin stimulating agents and IV iron has been proven to be effective in increasing HB and preventing transfusion in multiple scenarios, including burn injury, gastrointestinal hemorrhage, various traumas, chemotherapy, and total hip arthroplasty. So this combination is quite well validated in other patient groups. It's not been validated in Jehovah's Witness patient group per se, but has been validated in other groups. And iron supplementation should be given to all anemic Jehovah's Witness patients to increase endogenous erythropoiesis and maximize the efficacy of the erythropoietin stimulating agent. And you want to use IV iron. These patients typically have an element of anemia of chronic inflammation or anemia of chronic disease, which will prevent any absorption of gut iron. So oral iron is just not going to be absorbed. You need to give IV iron. There's no scientifically established dosage, but the authors of the Michigan Protocol suggest iron sucrose, 100 milligrams daily IV for 10 days. Or you can carry on even until you feel the HB is stable, and you can consider higher doses. Other sort of supportive therapies include vitamin C. It's not There's no strong evidence base to show that it does help, but theoretically it does help with iron store mobilization in terms of physiology, and it's probably not harmful to give vitamin C. And in this protocol, they start folate and B12 therapy immediately on initiation of the protocol. They take folate and B12 levels just before initiating the protocol and wait for the results. And based on the results, they'll decide whether or not to continue the folate and the B12. And they strongly emphasize minimization of phlebotomy. The authors recommend only drawing 1 ml of blood every 48 hours, preferably to use a blood gas machine and pediatric tubes, and do minimal so-called routine testing, which is in keeping with international expert opinions, such as this opinion from the Critical Care Society's Collaborative. A couple of years ago, they said 5 things physicians should question. And number 1, they said they were questioning the value of doing routine diagnostic tests every day. They suggest that you should actually only order tests to answer clinical questions, because doing routine blood tests increases healthcare costs, has not been shown to benefit patients, and may actually induce anemia due to unnecessary phlebotomy. So that's in keeping with international sort of expert guidance. I want to briefly mention the hemoglobin oxygen carrier. The most successful product was the HemoPure, which was once available in South Africa. I tried to find the circumstances under which it was registered. It seemed to be quite dodgy, to be honest, because the product had never actually gone through clinical trials and was essentially given to South Africa as an experimental product. The CEO was eventually arrested for fraud, and the parent company went bankrupt. However, the product was taken over by another company, but that company only makes it available for research and compassionate use to some centers in the USA. So for us in Africa, this is more of a theoretical discussion because we don't have access to the product. However, it has, according to the authors of the Michigan Protocol and various case studies, shown a use as a bridging therapy between life-threatening anemia and the time it takes for the erythropoietin stimulating agent to restore the HB. 1 unit of HemoPure increases the plasma HB by about 0.63 grams per deciliter, and the half-life is approximately 19 hours. It's associated with lots of morbidity, methemoglobinemia I mentioned, but there are also other complications of this drug and of this drug class, which essentially has made most countries very, very wary of registering these products for clinical use, and in general, they're not readily available because most sort of regulating agencies are too frightened to sort of register products because there's so many potential morbidities that can be caused. Okay, so the authors of that Michigan protocol also gave sort of 6 sort of case studies, and these graphs, I think, illustrate the effects of their protocol quite nicely. They had 3 patients that were pure medical patients, and then 4 patients that they needed to prepare for theater. So in the medical patients, we had HBs hovering around 4. One was about 3.5 when they initiated the protocol, and you can see by day 7, there's a noticeable rise in HB values, with the patient HBs going up to above 6 or above 7 in these cases. And then they had similar results with the pre-op patients. Usually around about day 7, the HB starts going up and the patients were ready for theater around about day 7. This particular patient was bleeding constantly and had to go for an emergency procedure, and HB was 4 post-op, but they provided supportive therapy and took a bit longer for this patient to respond, but eventually the HB shot back up to almost 8. So they felt their protocol seems to be quite working based on their limited sort of case series. I found another protocol published by the Koreans from Sunchunhinag University. I hope I pronounced that right. They use lower doses of erythropoietin, and they also tailor the erythropoietin dose based on the HB. So if the HB is between 5 to 7, they'll give about 300 international units per kilogram per day, which is about 20,000 units for an average-sized adult, and they'll give it every other day rather than daily. But they also give IV iron. They give higher doses of 200 milligrams a day, and they will routinely supplement with folate and B12, regardless of the underlying folate and B12 levels. Once the HB is less than 5, they'll go up to 40,000 units every other day. And they also published some cases, but they only published 2 cases in their article. With one patient sort of not needing a surgery, starting from an HB of 4.5, and they discharged with an HB of 9.1. They seem to have a slower response time because it's only around about day 14 that the HB really started rising. And then this patient had to go to theater. HB dropped all the way to 4.1, and then using this protocol, they got about 3 weeks later, they got the HB up to 10. All right, looking at the cost. So if you had to follow the Michigan protocol of 40,000 international units per day, that's going to be about 5,500 rand a day. The iron, the cheapest one I could get was 800 rand a day. So that's going to be approximately 44,000 rand per week to use the Michigan treatment protocol, including the cost of all the vitamins. Comparing that to 1 unit of red cells, which is going to be either 3,000 rand for the non-leukocyte depleted or 5,000 rand for the more superior leukocyte depleted product. So quite a costly alternative compared to just taking blood, but that is the only real alternative to getting the HB up. So as I said, there's very little literature. So these are the 2 articles I used to sort of write this portion of the presentation. Both very, very nice articles explaining the rationale for their protocols. So you might ask me which one is the better one to choose. I'm going to say there's no scientific evidence to say which one you should use, or there's no scientific evidence to say that you can't just make your own protocol. But what both sort of articles emphasize is that every hospital, every large sort of practice should have a written sort of document for how they would want to treat patients that are refusing blood products, and it ideally should be a multidisciplinary consultation, and try and have a standardized approach to your patients. I think having a standardized approach would be quite nice also for publishing case studies. We've got nothing from Africa. And I mean, you don't even need a lot of case studies, it seems, to get published. So it would be nice to sort of collaborate and get some case studies published. Next product I want to discuss is fresh frozen plasma. So there's a bit of nuance in fresh frozen plasma, and not all Jehovah's Witness patients will refuse fresh frozen plasma, although most will. But plasma derivatives can be acceptable. So you need to talk to your patient and find out on a case-by-case basis what they are comfortable with. So for TTP, which is frequently treated with plasma exchange using fresh frozen plasma, cryopoor plasma is therapeutically equivalent. It is a waste product of cryoprecipitate production, and many Jehovah's Witness patients actually find it acceptable. So if they find that acceptable, just tell the South African National Blood Service that you want cryopoor plasma for your plasma exchange. and then you shouldn't have any further issues. If patients refuse this cryopoor plasma, case studies suggest that you can move to second-line therapy, rituximab and steroids, and you can do an albumin exchange, which most Jehovah's Witness patients are fine with, and there have been anecdotal case reports of response to that treatment. For the Jehovah's Witness patient who offer an overdose with bleeding and you need to control the bleeding, instead of using fresh frozen plasma, you can use a prothrombin complex concentrate. And there are two types. There's hemosolvix, which is human-derived from and available via Sanbus or via pharmacy. And there's Octaplex, which is non-human derived. So most Jehovah's Witness patients will say this is far enough from fresh frozen plasma that they're happy with it, but if they're not happy with it, you can give the Octaplex instead. For any other bleeding of a high INR, I found a very nice protocol published by the obstetricians who have had to deal with bleeding Jehovah's Witness patients. And they come up with a very nice protocol that in summary says, first give tranexamic acid, evaluate the patient. If the patient's still bleeding, give fibrinogen or cryoprecipitate. Patient still bleeding, reevaluate. Then you give the prothrombin complex. And as a last line, you give activated factor 7. But bear in mind that for any patient that's bleeding, make sure they're not hypothermic, not acidotic, and that they're not hypocalcemic, because you're not going to generate clots very efficiently if your body physiology isn't optimal. There are a lot of recombinant products entering the space. For example, there's also recombinant Adam TS13, which is being trialed in the US for the treatment of TTP and various other combination products. So likely plasma is going to be the first product to, in the next 10 to 20 years, have a full range of non-human derived alternatives. So this will become a solved problem, I think, in terms of managing the Jehovah's Witness patient. There's going to be lots of non-human derived alternatives in the coming decade arriving to the market. And just to mention that you should remember to control the menstrual cycle in females if they are bleeding. And we'll briefly mention how to induce amenorrhea on a later slide. Cost comparisons. So FFPs are about 2,500 Rand. Your albumin is 658 Rand. Tranexamic acid 160. Hemosolvix, so prothrombin complex concentrate, is 2,800 Rand. This is human-derived. Some Jehovah's Witnesses will be fine with it, some will not. If they're not fine with it, you go to Octaplex, but that's about 1,000 Rand more expensive. And then the last line therapy of Activate Nova 7 for the average sort of adult patient, you're going to need about 5 mils. So to reach this dose of 90 micrograms per kilogram, 5 mils is 76,000 Rand. So it's exceptionally expensive. I think that's the main reason why it's always last line therapy, to be honest. Mainly the cost. Okay, again, there's not much literature in the space, so I only found two very useful articles for plasma. Last product I want to discuss is platelets, and of all the products, platelets I think has the least amount of literature relating specifically to the Jehovah's Witness patient. But there are case reports that suggest good responses to thrombopoietin mimetics. So we do have one available in South Africa called eltrombopag. Can take up to 8 days to see a response and can take up to 2 weeks to see a maximal response. Other options to consider, in particular, if you don't have time to wait for that 8 days to see the response, or tranexamic acid, desmopressin, cryoprecipitate, and recombinant activated factor 7. I couldn't find any sort of guidelines suggesting which one you should try first or any sort of protocols. So I'd imagine it's the simplest thing, start with the tranexamic acid and work your way through to the most expensive product, which is the factor 7. And then patient, in particular, menstruating females can have very heavy menses with low platelet count, so consider medically inducing amenorrhea. Cost comparison, a platelet single donor product is 16,000 Rand. The Revolade, which is eltrombopag, thrombopoietin stimulating agent, is about 20,000 Rand for the low dose for a month's course, and double that for if you're going to have to give high dose. tranexamic acid is about 160 Rand. Desmopressin for the dose for acute bleeding is going to work out to about 8,000 Rand. And we already mentioned that the adult dose of Novoseven is about 76,000. So my references for the platelets. I just want to briefly discuss how to medically induce amenorrhea. Most of the studies in this have been done on soldiers, and there's one study done on female astronauts. But the most effective method is to give continuous oral or transdermal combined oral contraceptive. And by continuous, that means you must remove all the placebo tablets and all the patches. So don't give the patient any placebos. And that's got near 100% effectiveness. Unfortunately, there are many contraindications to the combined oral contraceptive pill. So if you have one of these complications, you'll need to move on to second-line therapy, which could include progesterone-only pills, which have variable effectiveness in inducing amenorrhea, the injectable and progesterones, which are a little bit more reliable than oral, and you can also give an intrauterine device that has levonorgestrel, but it's only about 50% effective. This is effectiveness in inducing amenorrhea. Even if you don't induce amenorrhea, you might still be able to reduce the duration and there's amount of menstruation. Those are my references for inducing amenorrhea, and that's it. So that was a short dive into what the literature says about Jehovah's Witnesses and what are the sort of alternatives to blood products you can use. There's not much literature, not much scientific evidence, but I hope something here will be practical and help to inform your practice and perhaps inspire you to make your own bloodless treatment protocols for your institutions for the management of these patients and other patients that refuse blood products. Thank you very much. Those are my contact details, and you're welcome to contact me if you want any of the references or to discuss anything regarding hematology.
Thank you so much. Interesting. And insightful. I'm not sure if anybody knows the answer, but does the medical aid cover it if the patient sort of chooses the more expensive treatment?
My guess probably not, because I think the indication there's really more. It's more for a religious region, so that means I think probably most likely they're unlikely to cover. Yeah. And I think most of the time then our options are limited. But one of the things just brought to add into the presentation is always saying, if you're known to be a Jehovah's Witness and you happen to be a female, I think it's very important that you have a frequent follow-up with your general practitioner or your physicians and have your iron product check on a regular basis, which should be almost like after probably beginning of the month, and make sure that your iron transfusion might be a constant phenomenon that should be done. And the HB is kept at certain levels, at least above 12, 13, because that can actually be accomplished. And that obviously prepare you for eventuality, what could happen, So because I think sometimes most of Jehovah's Witnesses actually live like the normal people until they fall pregnant, and other do not, they're very concerned because we know that iron deficiency is a very rarely thing in female, which is actually probably a normal phenomena, because most females having heavy periods, and some that can really need to be addressed. And I think probably the gynecologists obviously need to be educated about that, and perhaps, it's up to you, probably implement the kind of protocol a bit much earlier. And I think if your patient probably get irons, they got good enough irons supplements, and obviously in terms of transfusion and probably more folic acid, dietary kind of alteration that can actually meet their iron needs. And I think probably we can reduce the risk of complication, because then of days really need 1 or 2 weeks to make sure that actually you meet your iron demands. I think for months add on, yeah. And obviously, I think we're also concerned about iron transfusion. I mean, obviously, most of patients, I think, depends on the risk factors. And if iron obviously ones go below 7, the risk of hyperdynamic heart failure become a reality. And I'm not so sure about the experience of colleagues here regarding transfusion of iron transfusion in context of heart failure. I think some that you really also, I think we need to think about it, because also increase the risk of fluid overload of recently tumor concentration. And so there are quite a lot of things to be done. So I think we should not wait until emergency. We should act a bit earlier. I think that if you have any take on, on this medication. If you know any Jehovah's Witness patient, I think we need to do more education about that. But thank you. This is quite a beautiful presentation, and I just think that you're bold enough to take the bull by the balls, you know.
Thank you.
I would not have attempted it because it's a difficult topic, but thank you so much.
So would you then give iron? So you obviously would do an iron study as part of your workup. Would you then just give iron until the iron is supplement? Because the ferritin is probably going to
Specifically, if you're trying to get the HB up. No,
would you then continue even if the iron is normal?
Yes. So the idea, if you're giving such high doses of erythropoietin, even if your iron stores are normal, your iron stores will not mobilize fast enough to make full use of that effect of erythropoietin. So you actually have to gently iron overload the patient to get the full effect of the erythropoietin. So the idea is not to supplement iron deficiency. The idea is to give the patient iron overload so that they can make full use of the erythropoietin and push, and that increases the speed of the increase in the HB.
We actually had a patient very recently. I think it was post C-section. And when I saw her, she had IV iron. She was also given oral iron, and I actually didn't know that, so I did stop the iron supplementation because it looked like she had now excessive iron. The iron was not done before it was given, but then I would have. Now I'll treat it differently.
I think probably the most important thing is that maybe we should just clarity that ferritin is not a kind of a marker for iron deficiency. So it's really an acute phase protein that can actually vary depending on the inflammatory process. So we should not be using ferritin actually to mark whether the patient is iron deficient or not. Though most medical aid wanted to show that their ferritin is low. But in the context of somebody, renal failure, some of the acute problems, their ferritin will be very high. So, but we should be using more the iron saturation, I think, and then plus the iron levels, because if it's low, that's what you need to replace. That's why your iron is more direct to replace the iron than ferritin, actually. Yeah. So I think we should not be guided by ferritin level. Darren, do you have any question or guidance or remarks?
Just to say thank you. And the only question I really have is on that erythropoietin dose. So one of the big issues we have with erythropoietin under normal use in the chronic renal failure patients is that obviously it causes hypertension. So I'm just wondering what effect would such a massive dose of erythropoietin have in terms of the cardiovascular status of the patient? And then just while I was thinking about that question, I was wondering if anybody knows, can Jehovah's Witness patients receive dialysis? Is that considered transfusion?
I think dialysis, no. I think they could get dialysis, not a problem, as long as there's no blood products. Because I think that, it's not, I don't think that, I think actually very interesting question. But I think numbers shouldn't be a problem, but you never know, I think I need to look up into that, because that might become a real challenge in future. Self-saver? Yeah.
No, I think they do.
But it's
but it's their own. If it's a closed system, I think there was something about if it's a closed system, then it's fine. So that's why dialysis is fine.
Because it's very complicated because you don't know how to deal with it now.
And then just I think I remember a few months ago there was new oral erythropoietin tablets that it actually takes for chronic dialysis patient. I think I remember. And will that be an option for Jehovah's Witness who have low iron that maybe skip that earlier, 3 months before, if we know that they're on their, on the, obviously on their time of probably having children to make sure that the iron stay up? Do you think is there an option for that? Any literature?
No, I didn't see any literature, so that would have to be something that someone would have to.
But it's something new, yes, something new, oral erythropoietin.
Or pre-op. It's really interesting.
But
it's probably going to be expensive. There is a subcutaneous one, so.
So in that case, Leanne, anything to say?
No, thank you very much. We appreciate it.
You're
Yeah.
welcome.
Thank you so much. And I think, next week probably we'll sort out our internet problem, and maybe we'll have alternative way. But I think the podcast should be available. We'll make the podcast available on the LinkedIn probably this week by Friday to make sure that people can access those lectures, because there were a lot of interest. Unfortunately, I think we have issue with internet, something that I think I was born before tech, and I think probably I need to start learning about it. But thank you so much. I appreciated it. And time for us to taste your cake. Thank you, sir, really for a frustrating morning. I really have not even taken time to try to learn these themes. Well, this is the problem.